So I'm fortunate enough now to be joined by my fabulous thoracic nurse practitioner, my advanced practice provider, who I work with together, treating lung cancer patients at our center. Rasheda, thanks for joining.
Thank you, Dr. Levy.
You know, lung cancer, we talk about this all the time in clinic, how complex things are with lung cancer. And just 10 years ago, or 15 years ago, where everyone got chemotherapy, we're now moving into the era of targeted therapies and immunotherapies, and this whole idea of precision medicine with targeted therapies. So can you kind of go over just briefly the targets that we generally test for in our clinic, and then we can talk about the drugs as well?
So generally, we're doing the NGS on EGFR and ALK1, and ALK rearrangement and ROS1, and then even their PD-L1 status, which is on the tissue as well. So it's very important, and patients are coming with that knowledge, right?
They want it.
Of knowing what is being tested for. Are we testing this? So it's very important from an APP standpoint to understand what are these mutations.
Yeah, so you mentioned, you know, the NGS, the next-gen sequencing that we do, and just high level, the EGFR and the ALK and the ROS and the RET and the BRAF and then the PD-L1 as well. So just talking about targeted therapies, patients hear a lot about them. We have multiple targeted therapies approved now. So specifically in the EGFR space, we've witnessed some changes recently. Can you talk just a little bit about this?
Sure. Yeah. I mean, it has been great change, right? Because in an EGFR world, we've had the first and second generations, and then here recently with the,
Tagrisso.
You know, it has really improved symptom management, having the understanding of how it's indicated for, and recently, in the last couple of weeks, even for first line. So that is very amazing for lung.
You know, we've used this drug a lot for patients who were in the refractory setting after getting erlotinib or gefitinib or afatinib, if they were T790M positive. And now we're being able to move this front line for every patient where if you're EGFR positive and you have a sensitizing mutation, you can get this drug. Similar thing with alectinib and ALK, right? I mean, we've got a new indication for that as well. So, you know, with all of these new targets and all of these new targeted therapies, I think APPs, like physicians, need to maybe be disease-specific or disease-focused.
I absolutely think, especially in academia. Now, I know in community practice that can be a very big challenge, but definitely with the ongoing new changes that are happening in oncology, especially in lung, it is a need to know the disease. It's no longer safe for us just to know symptom management control, right? We need to know an understanding on a scientific level of what is going on with the disease. What does this genetic mutation mean? What does PD-L1 expression mean? What if I have a low expression? What you as an APP have to know more than just the bare minimum and just the side effects.
And it's not just with targeted therapies, and we'll talk in a second about how you do this, how you keep up with things. It's not just with targeted therapies that you have to know this, but with immunotherapy too.
Absolutely.
We have new biomarkers for immunotherapies. We have
TMB, you know, it's just not if they have a PD-L1 status. Now we're looking at their tumor burden, mutation burden, to see if they will respond with immunotherapy, right? Because, you know, patients want to know that precision medicine, you know, want to know whether or not, just because I have a PD-L1, am I going to really respond with it? And I think that's the next level of what we're going to.
It's such a great comment, because I think patients are so motivated to understand what the right drug is for them. And the onus is on us, not just as physicians, but APPs, to deliver that drug. You know, with targeted therapies, we do next-gen sequencing on every patient. If we identify a target, we give them a targeted therapy. Same thing goes, as you just mentioned, for immunotherapy. You know, we're doing PD-L1. We may start doing tumor mutation burden. We're trying to find the right patient with immunotherapy, and sometimes immunotherapy is for all patients up front in combination with chemo. But with all this complexity, you know, you talked about the need for keeping up with how does an advanced practice provider, a nurse practitioner, as we function as a team, how do we keep up with this? How do you keep up with this?
Well, there's multiple ways, right? One of them is the importance of pairing with a great physician that is willing to teach, willing to answer questions, But the onus is also on the APP. You know, it's doing CMEs, whether that's online, whether that's in person, whether that's conferences, whether it's reading journal articles. It is important. I can't say it enough. It is not enough just to know the side effects of the drugs. It is so important to know the disease and the ever-changing treatment options that are coming out. It seems like almost every other week.
Yeah, it's overwhelming.
Yes,
I mean, it's overwhelming for physicians, and I think it's overwhelming for nurse practitioners and advanced practice providers, and that really underscores the importance of doing the things that you mentioned, the CME, the journals, so that if you are functioning with a physician and it is a team and you are disease specific, even if you're not, you know, I tell the community physicians, I don't really envy you. You have a hard job keeping up with multiple different disciplines. I just had to keep up with lung, and we still have a hard time. Sometimes we talk all the time about what to do with patients and trying to understand the conflicting data that we have out there. So, you know, you've mentioned how important it is to keep up with the data, but I think one of the things that you do so well in addition to keeping up with the data is you're the tie into our practice a lot of the times. You know, with all the things going on with our patients, talk to me about, and I know what you do, but I want to hear it again, how you communicate with the importance of communication for the multidisciplinary team, because the other segment that we did was, you know, with a pathologist and a pulmonologist and how integral they were to the team. You're the one doing a lot of the communication, so go walk us down that road.
So I think it's that continuity of care, right? It's not just the onus on the physician. It is important as an APP. What I usually do, I'm tracking down things that may not have gotten in a timely manner as we, you know, suspected, or a patient we're seeing in clinic that needs a more urgent visit with the pulmonologist, you know, or if we need to do more tissue, did it get to the right place, and so forth. So it is very imperative that it's not just the relationship with the physician in the clinic, in the med-onc clinic, but also those other interdisciplinaries, you know, pulmonology, radiology, you know, infusion center, even outside, you know, primary cares who may refer the patients in. Communication is key because there's no way that it can work seamlessly without, you know, being able to communicate.
And I think that lung cancer and all cancers for that matter have become so complex that you have to communicate. And I think you touched upon it quite nicely, you know, making sure you do a great job at this, much better than I do, reaching out to the pulmonologist and say, hey, this patient needs their pleural fluid drained. Specifically reaching out to the pathologist and saying, what are the moleculars on this patient? And even as you mentioned, the other disciplines, the primary care physician, to make them aware of what's going on. And also these second opinions that we get a lot of the times, and making sure that we've got the tissue. And so I think that's such a huge role for an APP, not only to be able to learn the data and deliver, but also to be the one who's really marshaling the charge to get all the information together as best as possible so that the best plan can be made for the patient.
Absolutely.